So let me discuss what exactly you mean by the hypertensive crisis. So the question is, an individual is having headache and profuse sweating, and on examination his blood pressure is around 200 by 120 millimeters of mercury. Which of the following should not be used? Now in this particular hypertensive crisis we have two terminologies. One is hypertensive emergency and the other one is hypertensive urgency. So let me take up the discussion of the hypertensive crisis, in which I'll be discussing about the hypertensive emergency and as well as hypertensive urgency. First, if you see the management of hypertensive crisis, first and foremost, you should know, right? You should know what do you mean by this word hypertensive crisis. If the systolic blood pressure of the individual, if it is more than 180 millimeters of mercury, and diastolic blood pressure of the individual, right, diastolic blood pressure of the individual more than 120 millimeters of mercury, then we use the word hypertensive crisis. Right, then we use the word hypertensive crisis. Now, if the individual is having higher systolic blood pressure or higher diastolic blood pressure, or when the individual is in a state of hypertensive crisis, what we need to check is, we need to check if the individual is having any target organ damage or not. I will tell you what are all the target organ damage. So we need to check if at all, if the individual is having the target organ damage. If the individual is having target organ damage, then we use this word, what is called as hypertensive emergency. Right, hypertensive emergency. Next, if the individual is not having target organ damage, then we use the word, what is called as hypertensive urgency. Now, if the individual is having hypertensive emergency, what are the steps you need to take? First, you admit the patient in ICU. First and foremost, very important thing is you need to check whether the individual is having any aortic dissection, because among all the conditions which will cause hypertensive emergency, if the individual is having associated aortic dissection, you need to take utmost care to reduce the blood pressure immediately less than 120 systolic blood pressure. Otherwise, there will be progression of the aortic dissection and where they can have the rupture of the aorta. So you need to check whether the assess for aortic dissection, or if the individual is female, assess for the development of eclampsia, that is along with hypertension, if the female, if she is having any seizures, or check if there is any important endocrine disorder, that is pheochromocytoma. Right, that is pheochromocytoma. Now, if any of this is there in this individual, what you have to do, let me tell you now. So in one side of the clinical scenario, yes, above all are present. That means the individual is having either aortic dissection or eclampsia or the presence of the pheochromocytoma. What you have to do is you have to reduce the blood pressure, systolic blood pressure less than 140 millimeters of mercury during the first hour, or you have to reduce the systolic blood pressure to less than 120 millimeters of mercury if the patient is having the aortic dissection. Right, if the patient is having the aortic dissection. Next, you take another side of the story. That means above clinical scenarios are not present, but the individual is having hypertensive emergency. Right, there is no aortic dissection, or the patient is not pregnant, there is no eclampsia, or there is no pheochromocytoma. In that clinical scenario, you have to reduce the blood pressure definitely, but the amount of the blood pressure that you have to reduce is maximum of 25% of the systolic blood pressure in the first 1 hour. Okay, so you have to reduce the blood pressure by maximum 25% over 1 hour. Okay. And then you have to gradually reduce the blood pressure over the remaining 24 hours. So this is what you have to do in a patient with the hypertensive emergency. Whereas you take in patients with the hypertensive urgency. In hypertensive urgency, there is no target organ damage, right? So you need not admit the patient in the ICU. This patient can be managed with the oral medication as well. So you need to intensify, right? You need to intensify the oral treatment, right? Now, let me tell you what are the medications you give in case of the hypertensive emergency and what are the medications you give in patients with a hypertensive urgency. What is the basic difference I have said you? The basic difference is in patients with emergency, target organ damage is there. In urgency, there is no target organ damage. So you take in emergency first. In emergency, you have to give the intravenous medications, not the oral medications. You need to admit the patient in the ICU and you need to give the intravenous medications. These intravenous medications, either they could be diuretics or they could be vasodilators or they could be adrenergic inhibitors. Right, adrenergic inhibitors. You take the diuretics. The diuretics, what you have to give is furosemide. And you take the vasodilators. The vasodilators, what you have to give is nitroglycerin, phenyldopan, nicardipine, right, which is a calcium channel blocker. Then we have hydralazine, which is an arteriolar vasodilator. Next we have enalaprilate. Right, these are the medications which are used as vasodilators which can be given in patients with a hypertensive emergency. You take the adrenergic inhibitors. Remember the adrenergic inhibitors, they include phentolamine, next we have esmolol, which is a beta blocker. Phentolamine is an alpha blocker. Then we have metoprolol, right, which is also a beta blocker. Then we have labetalol. Labetalol, it is both alpha and as well as beta blocker. And then we have urapidol. So these are the adrenergic inhibitors. Remember, all these drugs, they are used in hypertensive emergencies. They are given as the intravenous agents. Next. Now, let me tell you what are the drugs which are given in case of the hypertensive urgency. In hypertensive urgency, I have said you it is the oral medications what you have to give. Intravenous medications are not required. Now, let me tell you what are the drugs in hypertensive urgency you can give is nicardipine. Remember, nifedipine, it is not recommended now. Why nifedipine is not being recommended is because nifedipine can cause abrupt fall in the blood pressure of the individual. That is the reason why the individual can land up in either myocardial ischemia or cerebral ischemia. That is the reason why nifedipine is not being given presently or in the present clinical scenarios. Next, the other drug is the clonidine, which is centrally acting the sympatholytic drug. Then we have captopril, which is an AC inhibitor. Right, you can give oral labetalol. Then we have hydralazine, particularly this is an arteriolar vasodilator. Next we have the other drug, that is nitroglycerin, NTG. Okay, so whenever if you are giving nifedipine, that should be used with great caution. And another important thing is, nowadays, the drug which is not being used in patients with a hypertensive emergency is your sodium nitroprusside. So, remember, sodium nitroprusside is not used nowadays in patients with a hypertensive emergency. Why? Because this will also cause abrupt fall in the blood pressure of the individual. Next. Now let me tell you, like, what are the target organs which can be damaged in patients with a hypertensive emergency? Remember, in hypertensive emergency, so the target organs which can be damaged in the hypertensive emergency are, number one, the heart, right? Next, the eyes, kidney, the brain, and as well as the aorta. So these are the target organs which can be damaged in patients with a hypertensive emergency. What is a multiple choice question here is, what is the target organ which is first affected in case of the hypertensive emergency? Remember, the first organ to be affected, right? The first organ to be affected is the heart. And what will happen to the heart? The individual will develop what is called as the left ventricular hypertrophy. And because of the left ventricular hypertrophy, there is increased oxygen demand. And because of this particular increased oxygen demand, the individual will develop subendocardial ischemia. Right? Because it's a hypertrophied heart and the supply is less. So they will develop the subendocardial ischemia. So this will be the first organ which will be affected as in patients with the hypertensive emergency. Now, let me tell you what will happen to the eye. These patients, they will develop what is called as hypertensive retinopathy. Right, these patients, they develop what is called as hypertensive retinopathy. And in hypertensive retinopathy, you have various stages. Now, let me tell you what are the stages in hypertensive retinopathy. In stage 1, remember, the earliest change what you will observe is the focal attenuation of the arterioles. Okay, so in stage 1, the earliest change what you will notice is focal attenuation of arterioles. Right, that is in case of stage 1. Next, you take in case of stage 2. In stage 2, what you will notice is, along with the changes of stage 1, there will be what is called as arteriovenous nipping, that is AV nipping. This AV nipping, this is called as Salus sign. Right? Next, you take in patients with the stage 3. Right? In case of stage 3, along with stages of 1, 2, these individuals, they will have what is called as flame-shaped hemorrhages. So in stage 3, along with stage 1 and stage 2, they will have what is called as flame-shaped hemorrhages. Remember, this particular flame-shaped hemorrhages can be seen even with trauma. Next, you take in patients with the stage 4. In stage 4, along with stage 1, 2, 3, right, along with stage 1, 2, 3, the individual will also have what is called as papilledema. That is, the individual will have swelling of the optic disc. That is what is called as papilledema. So these are the stages of the hypertensive retinopathy. Now let me tell you some of the important multiple choice questions here. That is, in patients with diabetes also, they will develop what is called as the diabetic retinopathy. In case of diabetic retinopathy, what is the earliest change? The earliest change in diabetic retinopathy is your microaneurysms. Right, it is your microaneurysms. Now, in diabetic retinopathy, what is the leading cause of the visual loss? So, right, this is not related to your hypertension, little away from hypertension. That is where you can develop retinopathy is diabetes. That is also one of the most common cause. So, the leading cause of the visual loss in patients with the diabetic retinopathy is tractional retinal detachment. Right, tractional retinal detachment. Next, now let me tell you another important question. What is the leading cause of visual loss in diabetic patients? See, remember, leading cause of visual loss in diabetic retinopathy is tractional retinal detachment, whereas leading cause of visual loss in diabetes mellitus patient, it is your macular edema. Right, macular edema, they can develop as a part of your non-proliferative diabetic retinopathy. Right, now, so these are the changes within the eye of the individual as a part of your target organ damage. Next, you take the kidney. Remember, in the kidney, what is the target organ damage an individual can develop as a part of your hypertensive nephropathy is your nephrosclerosis. Right, and in the nephrology section of mine, I have discussed in detail what will be the renal changes in malignant hypertension and what will be the renal changes in case of benign hypertension as well. Next, you take within the CNS what the individual can develop. Remember, within the CNS, what the individual can have is the hemorrhagic stroke. So remember, in the central nervous system, they can have the stroke. Right, due to rupture of the blood vessels, they can have what is called hemorrhagic stroke. Now, the multiple choice question is, what is the most common site of the hemorrhagic stroke? The most common site of the hemorrhagic stroke is your putamen. Right, next, the another important multiple choice question is, what is the artery of stroke? The artery of the stroke is lenticulostriate artery. Right, it is your lenticulostriate artery. Next, what is the investigation of choice? Right, what is the investigation of choice in case of the hemorrhagic stroke? It is non-contrast CT scan. Right, it is the non-contrast CT scan what you have to do. So this will be the target organ damage within the brain. Now let me tell you what is the target organ damage within the aorta. Remember, as a part of the hypertensive emergency within the aorta, right, within the aorta, the individual can develop what is called as the aortic dissection. Right, the individual can develop what is called as the aortic dissection. And what is the treatment? See, in aortic dissection, you have to see that the blood pressure of the individual is less than 120 millimeters of mercury. If the blood pressure is not maintained less than 120 millimeters of mercury, there is progression of the aortic dissection and the individual can have the rupture of the aorta where the individual will land up in death. So, as a part of the treatment in aortic dissection, what is the treatment you have to give is, you have to give intravenous you have to give intravenous labetalol. So this will be the management in patients with aortic dissection, and I have said you what are all the target organs which will be damaged and what will be the damage of that particular target organ. Now we have discussed what are the target organs damaged. Now let me tell you what is the treatment you have to give to that particular target organ damage not to occur in patients with the hypertensive emergency. So now we will take up the hypertensive emergency scenario, right, where there can be target organ damage. And let me tell you what is the recommended drug. And lastly, let me tell you what is the drug that has to be avoided. Right? What is the drug that has to be avoided? Now, for example, if the target organ damage in hypertensive emergency, for example, if it is the myocardium, where the individual is landing up in myocardial ischemia and myocardial infarction. In such clinical scenario, the drug what you can give is nicardipine and as well as esmolol. And the drug to be avoided is hydralazine. Next, let me take up that the individual having aortic dissection. The recommended drug is labetalol, or you can give esmolol plus nicardipine. Whereas the drug that has to be avoided is your hydralazine. Right? Next, you take the clinical scenario where the individual has developed ischemic stroke. Right? In this scenario, the drug that has to be, or the drug that is recommended is your nicardipine and the drug that has to be avoided is nitroprusside. Right? The nitroprusside has to be avoided. Next, you take the clinical scenario where the individual has developed acute pulmonary edema due to systolic dysfunction of the heart. Right? Acute pulmonary edema due to systolic dysfunction of the heart. In this clinical scenario, you have to give nitroglycerin plus loop diuretics to reduce the pulmonary edema, and along with that you have to give the beta blocker, that is esmolol. I'm sorry, you have to give nicardipine, not esmolol, nicardipine. A point that you should remember is, in case of decompensated heart failure, the beta blockers should be avoided. So, the drugs that should be avoided in patients with acute pulmonary edema due to systolic dysfunction will be your beta blockers. Right, beta blockers should be avoided, and as well as the hydralazine also has to be avoided. Next, you take the clinical scenario where the individual having acute pulmonary edema due to diastolic dysfunction. Right, diastolic dysfunction. In this clinical scenario, you can give the beta blockers. That is, esmolol can be given, nitroglycerin can be given, plus loop diuretics can be given in these patients. And lastly, if the individual is having hypertensive emergency in the form of acute kidney injury and developed a hypertensive emergency where the blood pressure of the individual is more than 180 by 120 millimeters of mercury, and the drug which is recommended here is the phenoldopan. Right, the drug which is recommended is phenoldopan. So remember, what did we discuss? The sodium nitroprusside is not being used nowadays because it will cause significant fall in the blood pressure of the individual, where not only that, the sodium nitroprusside is also associated with the cyanide toxin. So that is another reason why it is not being recommended nowadays. Now, going back to the question, person has headache and profuse sweating, and on examination his blood pressure is 200 by 120. Which of the following should not be used? So what is this? The patient is in hypertensive crisis, and along with that the patient is having headache and as well as profuse sweating. That means headache suggestive, maybe suggestive of the hemorrhagic stroke, right, where the individual is having the target organ damage as well. So what did we discuss? In patient with the hypertensive crisis or hypertensive emergency, the sodium nitroprusside is not being recommended nowadays, and nifedipine is also not being recommended nowadays. So the answer is both A and as well as B. Next, the other important thing what we need to discuss is the drugs that can be given in pregnancy, the antihypertensive drugs that can be given in pregnancy. Now let me tell you, I give you all the list of drugs. Let me tell you what is the drug of choice in hypertensive crisis in pregnancy, right? So let me discuss the antihypertensives given in hypertension in pregnancy. Right, hypertension in pregnancy. Okay. The mnemonic for this is better mother care during hypertensive pregnancy. Right, better mother care during hypertensive pregnancy. Now, B stands for beta blockers. And the beta blocker that can be given is labetalol. Remember, labetalol, it is also having alpha blocking activity as well. You take the word M, stands for methyl dopa. You take the word C, stands for clonidine. You take the word D, stands for dihydropyridine calcium channel blockers. Right, the dihydropyridine calcium channel blockers include like amlodipine. Next, you take the word H, stands for hydralazine, and you take the word P, stands for prazosin, right, which is an alpha blocker. And which is the drug of choice for the hypertensive crisis in case of pregnancy? It is IV labetalol. Right, this is considered as the drug of choice in case of hypertensive crisis in pregnancy. Right, now after having discussed about the hypertensive crisis, now let me take up the clinical scenario, what is called as resistant hypertension. You see the question here. Resistant hypertension is when goal is not achieved with 4 drugs plus diuretics, 2 drugs plus diuretics, 3 drugs plus diuretics, 5 drugs plus diuretics. Now, let me tell you, when will you use the word hypertension is, that is, when the individual is on 3 classes of antihypertensives, right, when the individual is on 3 classes of antihypertensives of different classes. Right, of different classes, and the 3 should be different classes. One among that should be diuretic. Right, one among that should be diuretic. And remember, all these 3 different classes, whatever we are using, they should be of maximum dose. Right, they should be of maximum doses. So all these 3 classes, maximum doses. Out of these 3 class, one should be diuretic and that should be of maximum dose. In spite of using these 3 classes, still if the blood pressure of the individual is not being controlled, then we use the word resistant hypertension. So the answer here is 2 drugs plus diuretics. So this is what is called as the resistant hypertension. Now, let me discuss one more multiple choice questions which can be asked on hypertension. There are certain clinical scenarios where you have unequal blood pressure in both the limbs. Now, let me discuss what are those clinical conditions where you have unequal blood pressure in both the limbs. Let me discuss the conditions where you have unequal blood pressure between the right and as well as the left arm. So one among that very important is your Takayasu arteritis, right? Takayasu arteritis, it is a large vessel vasculitis. In case of Takayasu arteritis, remember, these individuals can have unequal blood pressures between the right arm and as well as the left arm. Next, the other condition is when the individual is having what is called as the coarctation of aorta. So in patients with the coarctation of aorta, they can have unequal blood pressure between the right and as well as the left arm. But always it depends upon where exactly is the site of coarctation. Next, if the individual is having supravalvular aortic stenosis, right? I will tell you why in supravalvular aortic stenosis you will have unequal blood pressure. See, remember, in case of the Takayasu arteritis, the most common vessel which is being affected is the subclavian artery. And if the subclavian artery which is being affected unequally in both right and left, then the individual can have unequal blood pressures. And you take the coarctation of aorta. If the individual is having coarctation distal to the left subclavian artery, the individual might be having equal blood pressures in both the upper limbs. But if the coarctation is preductal, that in the sense, if it is proximal to the left subclavian artery, then the right limb, the blood pressure will be normal, and the left upper limb, the blood pressure will be on the lower side, if the coarctation is proximal to the left subclavian artery. Next, in case of supravalvular aortic stenosis, we have an effect which is called as the Coanda effect. Now, what is this particular Coanda effect is? Remember, it is a tendency of the jet stream which is coming from the left ventricle into the aorta, where the jet stream is adhering, right? It is adhering to the right aortic valve, right? It is adhering to the right aortic valve. So when the jet stream is adhering to the right aortic valve, in such clinical scenarios, there will be disproportionately higher blood pressure in the right arm. Right? Disproportionately the higher blood pressure in right arm. So this is seen in patients with the supravalvular aortic stenosis, right? And in patients with the supravalvular aortic stenosis, the murmur is the ejection systolic murmur, right? The murmur is the ejection systolic murmur. Next, the another clinical scenario where you can have unequal blood pressure in both the upper limbs is in patients with the aortic dissection. Right, in patients with the aortic dissection, they can have unequal blood pressure in both the upper limbs. Next, lastly, in patients with the obstructive aortoarteritis, right, aortoarteritis. So in obstructive aortoarteritis, it all depends upon where is the level of obstruction that will make the individual to have unequal blood pressure in both the upper limbs, that is right and as well as the left arm. So these 5 conditions you need to remember: Takayasu arteritis, coarctation of aorta, supravalvular aortic stenosis, aortic dissection, and as well as the obstructive aortoarteritis. Next. Now, we have discussed various etiologies of the secondary hypertension. We have discussed the renal pathologies, endocrine pathologies, respiratory pathologies, cardiovascular pathologies, and we have discussed even certain drugs as well. Now, see, depending upon certain clinical features, we can assume that the individual might be having, or the individual is having, this reason for the secondary hypertension. Now, let me take up that particular etiology of the secondary hypertension. What will be the clinical features and how do you work up for that particular secondary cause? Let me discuss. So I'll be discussing some of the important causes of secondary hypertension. Now, for example, if the individual is having secondary hypertension due to obstructive sleep apnea, right? Obstructive sleep apnea. What will be the features in these individuals? The individual will be obese, first point, right? The individual will be having disturbed sleep, because whenever the individual sleeps, the large, thick chest wall will be obstructing the trachea, and thereby the individual will have the apnea, due to which the individual can have immediate awakening due to apnea, right? So that will cause the disturbed sleep, and these individuals, they will also have resistant hypertension, right? Resistant hypertension. And what are the screening tests you will do in these individuals? How do you do, or how do you screen? The screening is done by a scale or scoring system that is called as Epworth Sleepiness Score. ESS stands for Epworth Sleepiness Score. And the other thing is overnight oximetry. Right? Overnight oximetry. So this is the screening test what you have to do for patients with the obstructive sleep apnea. Next, if the individual is having renovascular disorder, right? Renovascular disease. If the individual having renovascular disease, what would be the clinical pointers to tell the individual is having renovascular disease? Number 1, there will be recurrent flash pulmonary edema. Right? Flash pulmonary edema in the sense this particular edema is washed out whenever you give a dose of a diuretic. Next, this is seen in early onset. This is seen as early onset in women with fibromuscular dysplasia. Remember, fibromuscular dysplasia is one of the etiology causing renal artery stenosis. So, early onset in women with fibromuscular dysplasia. Now, how do you monitor or how do you screen? This is by renal Doppler. Next, you take in patients with a primary aldosteronism. In case of primary aldosteronism, remember, the clinical pointers are, along with hypertension, the individual will be having hypokalemia. Because in case of aldosteronism, the aldosterone levels are grossly elevated, and the aldosterone, what it will do, it will cause potassium washout. That is the reason why the hypertension with hypokalemia, you have to suspect the Conn syndrome. And how do you screen? The screening is done by aldosterone, that is plasma aldosterone renin ratio. Next, if the individual is having secondary hypertension due to drug abuse, right? What are all the drugs which are of abuse potential causing hypertension? It can be cocaine, it can be ephedrine, right? It can be amphetamines, and the other drugs of abuse is your nicotine, that is smoking. Okay, what are the clinical pointers? The clinical pointers is presence of tremors, presence of tachycardia, the presence of chest pain. And how do you screen these individuals? You have to do a urinary screening of these particular drugs. Right? Urinary screening of these particular drugs. Next, if the individual is having secondary hypertension due to renal parenchymal disease, right, due to the renal parenchymal disease, then the clinical pointers are presence of urinary tract infection, where the individual can develop pyelonephritis and can cause hypertension. You have to see the presence of analgesic abuse, because these patients with the analgesic abuse, they can develop renal papillary necrosis, one of the condition where there will be renal parenchymal disease causing secondary hypertension. Next, the presence of the family history of polycystic kidney disease, because polycystic kidney disease is an autosomal dominant type of inheritance that can cause renal parenchymal disease, where the individual can have hypertension because of excessive renin release. And how do you screen these individuals? You have to do a renal ultrasonography, or ultrasound abdomen will pick up if there is any abnormality within the renal parenchyma. Right, now, so you see here, in case of obstructive sleep apnea, obese individual, screening is Epworth's sleep scoring. Renovascular disease, clinical pointer is recurrent flash pulmonary edema, renal Doppler you have to do. Primary hyperaldosteronism, hypertension with hypokalemia, you have to do aldosterone renin ratio. Drug abuse causing hypertension, tremors or tachycardia can be there, you need to do urinary screening of that particular drug. Renal parenchymal disease, the clinical pointers will be urinary tract infection or drug abuse potential, or family history of polycystic kidney disease, and you need to do the ultrasound. So these are some of the clinical pointers and screening tests for the secondary hypertension. Now, we have also discussed the Mendelian causes for the hypertension, right? Like Liddle syndrome, Gordon syndrome we have discussed. Now, let me take up these particular scenarios where like the Mendelian causes for the hypertension. So, if you take the Mendelian causes for the hypertension, I have said you these are certain rare forms, right? We have certain autosomal dominant and autosomal recessive pathologies. And let me take up the first one, that is Liddle syndrome. Remember, in patients with the Liddle syndrome, they will have hypertension with metabolic acidosis. Right, with metabolic acidosis. Now, what exactly is the pathology in these patients with the Liddles? Remember, the exact pathology in the Liddles is there is gain of function of epithelial sodium channel. The pathology is gain of function of ENaC. ENaC stands for epithelial sodium channel. Now, what does this epithelial sodium channel do? This epithelial sodium channel, when it is acted upon by aldosterone, it will cause sodium and water retention and H plus ion and as well as the potassium excretion. So, there will be, so because of the gain of the function of the epithelial sodium channel, there is expansion of the plasma volume and there is also gain of salt. Right? These factors will lead to hypertension. And what is happening to the urinary loss? There is urinary loss of potassium and as well as H plus. And because H plus is lost, acidic media is lost, potassium is lost, so that is the reason why they will have hypokalemia. So this will lead to hypokalemic alkalosis. And what is the drug of choice? See, what is the basic pathology? That is gain of function of the epithelial sodium channel. What you do, you block the epithelial sodium channel. The drug which will block the epithelial sodium channel is the amiloride. Right, the drug that will block the epithelial sodium channel is your amiloride. So, hypertension with metabolic acidosis. I'm sorry, it is not metabolic acidosis. I'm very sorry. Right, it should be hypertension with metabolic alkalosis. Right, now, after having discussed about this particular Mendelian form, next let me tell you the another clinical condition where you have hypertension with metabolic acidosis. See, Liddle syndrome was hypertension with metabolic alkalosis, whereas here we have hypertension with metabolic acidosis. Now, this clinical condition is pseudo hypoaldosteronism. Right, pseudo hypoaldosteronism. Now, what is this is, in this clinical scenario of pseudo hypoaldosteronism, there is renal tubular unresponsiveness or renal tubular resistance to the aldosterone. So, in this clinical scenario, there is renal tubular unresponsiveness to the aldosterone, right? Or the renal tubular resistance to the action of the aldosterone. Now, this pseudo hypoaldosteronism, they are classified into two types. That is pseudo hypoaldosteronism type 1, and then we have pseudo hypoaldosteronism type 2. Now, you take the pseudo hypoaldosteronism type 1. This is the classic form. Right, this is the classic form. Whereas you take pseudo hypoaldosteronism type 2. This is also called as the Gordon syndrome, or this is also called as the chloride shunt syndrome. Right, both are one and the same. Now let me tell you what is happening in this Gordon syndrome. Remember, this particular Gordon syndrome, this is one of the autosomal dominant disorder, right? And here there is a mutation of the gene, right? There is mutation of the gene encoding WNK kinases. Right, there is mutation in the gene encoding WNK kinases. Now, what exactly will happen here? Now, what is happening? There is renal tubular unresponsiveness to your aldosterone. That means aldosterone is not showing the physiological action. When aldosterone is not showing the physiological action, now tell me a point here, will there be sodium and water retention? No, there is no sodium and water retention. So the sodium and water, it starts getting excreted out from the renal tubules. So thereby, what will happen in these individuals is, there is sustained volume depletion. Right, there is sustained volume depletion. And because of this volume depletion, what will happen to the renal perfusion further? The renal perfusion gets decreased. Once the renal perfusion is decreased, what will happen to the renin levels? This will trigger this will trigger the renin release. Right, this will trigger the renin release. Now, as and when the trigger is there for the renin release, what will happen? The renin angiotensin aldosterone system gets activated. The individual will develop what is called as hyperaldosteronism. Right, the individual will develop what is called as hyperaldosteronism. And because of this hyperaldosteronism, the individual will develop what is called as hypertension. Okay. Now, so this is what is called as pseudo hypoaldosteronism. Now, in these patients with the, why are we using the word pseudo hypoaldosteronism? As such, aldosterone is present in adequate levels, but it is not showing its physiological action. That is the reason why we are using the terminology that is pseudo hypoaldosteronism. Now, why do you think these patients have metabolic acidosis? Now, when aldosterone is not showing its physiological action, where do you think that the H+A1 will get secreted into the tubules and it get excreted out? No, it does not happen. So the H+, it gets retained in our body and that will cause metabolic acidosis. And why do you think they are having hypertension? Because of the trigger of the release of the renin. So this is what is called as hypertension with metabolic acidosis. So pseudo hypoaldosteronism type 1 is a classic form, whereas type 2 is your Gordon syndrome or your chloride shunt syndrome. So this will be certain rare forms, that is Mendelian forms associated with the hypertension, in which you have autosomal dominant and as well as autosomal recessive pathologies, right? So this completes the discussion on hypertension. Let me tell you in a nutshell what I have discussed. One, I have said you that the most common cause for the hypertension is the essential hypertension. And the most common cause for the secondary hypertension is your chronic glomerulonephritis. And we have many secondary causes, that is the endocrine causes, the renal causes, cardiovascular causes, respiratory causes, drugs and alcohol. right? I have given you the entire list. And later on I have discussed the clinical condition, that is the Mendelian forms which are associated with the hypertension, that is autosomal dominant and autosomal recessive form. Out of which Liddle syndrome, you have hypertension with metabolic alkalosis, and pseudohypoaldosteronism, that is hypertension with metabolic acidosis. These two you have to remember. Next, I have said you the clinical conditions where you have isolated systolic hypertension, that is atherosclerosis, or endocrine conditions like hyperthyroidism, and the valvular pathologies like aortic regurgitation. These are very important. And later on, I have discussed the clinical conditions where you have unequal blood pressure in both the arms, that is right and left arm. Like for example, you take in patients with the Takayasu arthritis, which is very, very important clinical scenario. Next is in patients with the coarctation of aorta. That too, it depends upon where exactly is the site of the coarctation. Next. And following which, I have discussed what will be the treatment of uncomplicated hypertension. That is, you need to give the diet, DASH diet. Next, lifestyle modification in the form of the physical activity, and the drugs also important in patients with the uncomplicated hypertension. And in patients with the hypertension, what is the morphological abnormality within the heart? They will develop what is called as hypertrophy of the individual cell of the heart. Ultimately, the individual will develop left ventricular hypertrophy. And later on, I have discussed about hypertensive crisis, in which we have hypertensive emergency and hypertensive urgency. Emergency, they require ICU treatment and target organ damage will be there. And the first target organ which will be affected is mainly the heart, where the individual can develop left ventricular hypertrophy, and they can also have the hypertensive heart failure as well. Okay. Then we have discussed what will be the problems in the eye, what will be the problems in the aorta, what will be the problems within the kidney. And later on, I have discussed what exactly you mean by the word resistant hypertension. So this is how the topic of the entire hypertension has been discussed. And you can see the section on the questions on hypertension. I will be discussing there mainly on the clinical based questions on the hypertension.